KNH was one of them, where people needed to come and live in Kibera or in slums so that they could get services. If you look at across the country now, there is no county that doesn't have a dialysis unit. So patients don't need to come to major towns to get those services. And what has happened in terms of human resource, if you look at renal nurses, from the year 2000, there were only 25. As we speak, we have almost 1,000 renal nurses, which is in the year 2024. So what does that tell you? Yes, you could be having very few individuals, and it's just because the financing mechanism hasn't been addressed. So what happens generally is you will have very few people. Once you address the financing mechanism, what happens is generally you have an increase in service provision, an increase in human resource, because what you have incentivized is output-based financing mechanism, where you provide a
I'm sorry.
service and I pay you,
Let,
and
let me just
and
interrupt
that
there briefly,
and
Dr. Mohammed,
and
because at face value, it seems to undercut the main argument that we've been hearing for the last hour, which is saying that we needed SHA in order to provide a new financing model, etc. But you're telling me, if I understand you correctly, NHIF started paying for this, for dialysis services. We saw a commensurate increase in the amount of centers that are offering the service and an increase in renal nurses. In other words, we already had a system that sort of worked, but here we are, we've junked that and we're trying something entirely new. I mean, that sort of
yes,
cuts the whole argument for SHA at its knees.
no, no, no. Now that's also the other part that you haven't still understood, which I want you again to understand. So NHIF was for members only. You have to have contributed and paid up for you to get a
Which is the same
benefit.
as SHA.
Wait, no, 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 no. You see, that's the problem. If you had understood clearly, you would have understood that SHA has three funds. There's the primary
With
health
the
care
with the
fund.
except with the except with the
Wait,
exception of the emergency healthcare side.
no,
If today, as
let
as
me
you guys have
explain.
said before, no,
Let me
no, hang on.
explain.
As you've said, right? If I am going to go and renew my DL, and you're going to ask me, oh, by the way, Chief, umelipa SHA, right? I will not get services unless I've paid up. In the same way that if I go to a hospital and I'm admitted, well, say not this time, but this time last year, that hospital would also essentially ask, but do you have NHIF cover?
So, if you had allowed me to explain, then you would have understood. If you, let me finish first, so that we are on the same page. So with SHA, you have the primary health care fund, and you have the social health insurance fund, and you have the emergency, chronic, and critical illness fund. So for the primary health care fund, all you need to do is to have registered. That's it. And then you get services at level 2 and 3 for free. You don't need to have paid anything. You just need to have registered, and that's it. For
I mean,
social health insurance,
it's not technically free though. It's essentially paid for by government, right?
yes, yes.
The same
So,
government that
so
is
now,
fiscally constrained.
no, now, yes, but that doesn't mean it can't pay for people, even if it's physically constrained. We have free primary education, and we are still physically constrained, and it's still being paid for. So let me finish so that we are on the same page. The emergency chronic critical illness fund, emergency, you don't even need to register for you. That's what we are saying. So you cannot say NHIF is equivalent to SHA. NHIF is equivalent to the second fund, which is the social health insurance fund, which is for people who have contributed and who are paid up. That is the fund that is equivalent to NHIF. Actually, the difference is for NHIF, you needed to contribute and you are supposed to wait for 2 months before you start. For SHIF, you don't need to wait. You pay it up today, you get services today. I hope that clarifies.
Well, to some extent, but not entirely clear. I want to bring up a press release that I believe SHA put up in the People Daily today. and you're asking employers to register their employees. According to that, 15,500 employers have registered 120,000 employees. But at the same time, as we spoke, I think it was about 15 or 20 minutes ago, you've migrated the records of at least 9 million people across the board. Um, if you've already migrated the records, why do employers then need to register their employees?
Because so what we need to do is, you see, previously employers were paying through the bank directly with a byproduct. So currently what we have is employers need to register, because for this month people who are employed formally will automatically benefit without having contributed the 2.75%, because these are the people that we want them to declare that they get the social health insurance fund benefits without having contributed, which they will contribute at the end of the month of October, beginning of November, between 1st to 9th of November. That is what we meant by declaration, uh, because you could have been moved, you were formally employed at that time, but uh, 1 month or 2 weeks ago, you have left employment and you are jobless currently. So we want your employer to say Rama is my employee, so that in the eligibility, we put you as a paid up member rather than someone who has not paid up. I hope that clarifies that communication.
So, in essence, you're asking employers to provide more data to clarify the status of individuals. So, you know who's essentially being paid for by the quote unquote, whose payments being routed through an employer vis a vis who's self employed or has an irregular income.
Yes, yes, yes.
Separate question here. I think it's from Ruhangi. Oh, my bad. This actually came in around 40 minutes ago. Do contributors benefit from insurance relief?
It was in the finance bill that was rejected. Contribution to SHA was supposed to have been a part of the relief. So you will have to wait for another finance act.
Right. Okay. Let me see if there's a whole bunch of other questions that came up. Um, Apologies. I'm just going to scan through this fairly quickly. Um, um, I'm going to go back to one of the questions that Fiona Kadia gave us just before the space started. Given the widespread resistance that we're seeing from Kenyans and the anger that they're seeing to essentially seeing more money, more of their little cash essentially being taken up by government that they see is essentially wasting a lot of it, how do you plan to implement the rollouts to ensure maximum participation?
This is, I think, the only act or the only legislations, the main legislation that I would say has had so many engagements, from public participation when it was being drafted last year to the continuous sensitization that's ongoing. The only challenge that we are facing is so much fake news that's being spread, starting with people saying we are contributing more, which is not the truth.
But have the
And,
some
and,
people
and
are contributing more in
some,
absolute
some,
terms,
some, some,
right?
if
They are.
someone
We
says,
can't
no,
just
no,
say
no,
that,
no,
we're not dismissing those individuals or saying, look, hang on a minute, I'm
which,
moving from essentially spending six
no, no,
thousand
no.
shillings a year to 30,000 shillings, and then we're saying that's fake news. I mean, it's
No,
a
no, no, no,
reality for
no.
them. That's an
It's
opportunity cost you're imposing on them.
yes, yes, it's a reality. But you see, when someone generalizes and says, we are, it's not we. You can say, I am paying more, because that now becomes an individual. Because if we compare the people who are paying more and the people who are paying less, actually, a reduction. So I'm not hearing the people who are having a reduction saying, oh, for the first time, I'm paying less in this new contribution. And who are the majority? Almost 60% that I have told you, they have a reduction, not an increase. But The 5% are the ones who have seemed to have amplified that and created this perception that the new SHA system is increasing the contribution. And the
Well,
second thing that is not,
it's
wait,
taking a bigger chunk out of their salary. So I don't think it's
yes,
fair for anyone to say, well, your concerns are invalid.
no, no, no. I'm not saying your concerns are invalid. You have been paying for a long time 0.017% if you earned a million, while your house help was paying 5% of her salary.
Yeah,
And
but even that zero
you can
point something percent figure is questionable to the extent that, given the examples that I gave you earlier, those same people are paying for private medical insurance premiums. Their employers are probably paying more. They're also paying premiums for other individuals, right? And we can see
yeah.
that in all of the data, and all of the studies that have been done by the experts groups that were cited earlier by Dr. Moy. So the zero point something percent in and of itself is a misnomer. It's a bit of a red herring.
It's not a red herring, it's the reality. You see, the 1 shilling, the utility function for 1 shilling for a person who earns 5,000 is not comparable to the guy who earns a million shilling. But that's neither here nor there. But the other thing that's not being said and it's not being mentioned is you have access to free primary health care, which is also reduces the burden of disease for us in this country. If we address our primary health care, we would, and we have people accessing proper primary health care, we will reduce 80% of health needs in this country. And that's the reason why that is a tax funded the benefit. And the other thing that primary healthcare is supposed to do is screening for cancer. That means also we are trying to reduce the burden of cancer, which we unfortunately find at stage 4 or when it's too late to do much assessment. So those are the things that we are not mentioning. That is beneficiary, yes, to the people who the 5% is an issue because they have their own cover, they can do all those screening that they need. But we need to realize that there is a population that we need to take care of who will burden the health expenditure if we are not deliberate enough to give them the necessary care and the necessary screening so that we reduce our expenditure on health.
But in
So
theory,
this,
Abdi, what stopped individuals from getting cancer screening in the first place? Because the counter argument could be made that if individuals do not engage in healthcare seeking behavior because either they don't have the income for it, which is a reality at the moment given the decline in purchasing power over the last decade, or they know that if they go to primary healthcare facilities, they're going to deal with overburdened nurses or facilities that don't have access to medicine, don't have the personnel. I mean, those problems could have been sorted out. The screening problem, rather, that you posit, could have been sorted out by other means other than creating SHA.
the screening would not have been sorted by other than the reason why we haven't had emergency fund for the last 14 years is because of this kind of thinking. If you look at emergency was in the constitution from 2010 as a right. No one implemented it. Come to 2017, the Health Act, it still amplified and said emergency is a right. No one implemented it. So this is the first time we are implementing that emergency. So it's good to say we will do, it can be done, it should have been done. Now we are at the level of doing. So what you need is to look at and say, yes, you have dared to do it. So let's see how it goes.
Well,
And let's see what will be
going
the outcome. You see,
right.
because all these things that we are talking about, focus on primary health care, community health, emergency. If you go back to our documents, policies, laws, you will find them nicely written from, I don't know when, 2000 or much earlier. but no one has ever dared to say, okay, how do we realize these policies and documents into a reality? And that's why we have the SHA. NHIF was mainly for members. It was a members club. You contribute, you get benefits. You don't contribute, you are outside of it. So the rest
How
of
do you
you
deal
remain outside of it.
how do you deal with the adverse selection problem that NHIF also had? Because in as much as you say it was a members club, the fact is that for a lot of people, it was a hell of a lot more accessible to contribute, 6,000 shillings into it in the year or 500 bob a month, whichever was more convenient for them. But more for the not, what would also happen is you'd have individuals who'd contribute when they were already in some sort of problem, right? And more often than not, this would crop up in the informal sector. And given the fact that I haven't seen a clear method for implementation here to compel people in in the informal sector to keep paying, I suspect you might run into the exact same problem that NHIF had with adverse selection.
And I think that's what Mwai can speak to it.
I can
Okay, okay.
I can come in. Thank you, Lama. If you look at our literature on insurances, the spiral killer of insurances, including the social insurances, adverse selection. And adverse selections, as you put it very well, arises because when you provide a voluntary mechanism or voluntary enrollment, people enroll when they are already sick because they have more information about their status. So they enroll when they are sick, and then after paying like 3,000 or so, or 1 month or 500 per month, they could even pay for 1 year. They come in and consume services, and the bill is far much higher than the contribution that they made. Now, that is exactly why we look at the one of the schemes that was the informal sector scheme, which if you look at our data for NHIF, because we are not saying that we are not, nobody is actually killing NHIF. We are improving NHIF to become a more robust social insurance as envisioned, rather than remain a members club as Abdi has highlighted. So when you look at the data there, you find for every 1 shilling that was contributed by the voluntary contributors, they spent 3 shillings. And that shows the unsustainability nature of a voluntary scheme in a social insurance. Therefore, a social insurance characteristic that it's mandatory. Is mandatory to remove that adverse selection you are talking about, so that people prepare earlier and they transfer the risk of getting sick from themselves to a social insurance that will pay for them when they get ill. Now, to deal with this issue, the fund has established 2 things. One is that the private sector, the employed people, the employer is limiting the funds and it commits to limit the resources for the sake of the employee. And therefore, that employee, when they find themselves sick, they just go to hospital and access treatment, and there is no adverse selection because they did not know when they will get sick. But the employer continue remitting. The second group is when you go through a SACCO. The SACCO or the aggregator, agricultural aggregators, like for tea, coffee, milk, name it, will also deal with the same. They will undertake to contribute for the purpose of remitting for social insurance, and therefore the contribution continue coming into the social insurance fund within the year horizon, and therefore you address the issue of adverse selection in that population. The last population is those who have what we would call intermittent incomes, and they are not in a SACCO. We are providing a premium financing product that we are developing, not with an intention of making resources from them. And the premium financing product works like this: that if I am an informal sector, my income is erratic. For instance, me, I come from Yaururu, where we sell potatoes. Potatoes grow every after 3 months. Then I will get into the enrollment platform. I will calculate my premium, the annual premium. I will go to the premium financing product. I will pay this for the health benefits. Therefore, I will have been assured that if I get sick, I will be treated and there is no adverse selection there. Then the premium financing product gives me an equalization pathway, just as the employed people, to be paying as erratic as my income comes in, provided I'm able to pay by the end of the year.
Sorry,
Therefore, we equalize.
who's providing the insurance premium financing? Is this entirely an SHA thing backed by funds allocated from the health ministry?
So there are two things. There are two main people who have come in to want to provide, two entities mainly that have come in to want to provide premium financing to make sure that the non-informal are able to be equalized with the formal in terms of contributions. Number one, and of course, navigating the adverse selection challenge, which is a key challenge in all insurances. Number one is there are donor funds that want to put in premium financing for certain populations of people. So they will provide through the SHA framework, provide some funds that will be given or rented to this informal sector who are not in cooperatives or in aggregates, and therefore they'll be equalized. Number two, the government is planning to put in some resources there also to make sure that it provides, if you look at the law tells the government that it need to provide a small fund to provide the premium financing through the Social Health Authority. So that one will make sure that the informal person who is a non-payroll has been equalized to be able to pay the premiums as their income comes across the year without having to cause adverse selection within the fund. So that's the thinking that we have input there
Dr. White,
as a stopgap measure to adverse selection.
Just to interrupt there briefly, because with respect to donor funding, we've seen instances in the past where reliance on other people's money becomes a critical point of weakness in healthcare. The blood bank system, for example, donor funded, and then eventually we as a country were not able to essentially run it properly. That essentially is in shambles at the moment. And we're still reliant on other people's money to fund, critical care in other chronic diseases, TB, HIV and AIDS, and so on and so forth. I mean, isn't that something that we should essentially remove
I've become transparent to you so that you understand what I mean. I say the government is putting a fund for that purpose, but there are also donors who have come. I don't want to say they have not come. Then after 2 months, you call me, you say government only, and there are donors who have come. So what I'm highlighting is that there are donors who have been providing social protection without a framework. They are saying that we have seen there is a framework here that we can use to provide these funds. This is a revolving fund. Remember, it's not like the what we have been doing with HIV, malaria, and TB. This is the resources that are provided. They will be paid back over the year. They are just cushioning the informal person not to be asked to pay the resources that they don't have.
So how much in aggregate
to level them, equalize them?
What the donors are putting in? Can you give us a number on how much they're putting in and the interest rates that we're looking at for premium financing?
So the donor that I am talking about, who I will not release in terms of name, of course, I want to highlight that we have gotten around 1.2 billion in terms of shillings that could be put in there. And we are also talking about an interest rate that is below inflation. And other one has talked about less than 3%. Actually, what they are talking about is largely of transaction costs to be covered so that they become a lifeline. It's sustainable over the period of when SHA is in operational and providing this service. Well, so that's the kind of thinking we are trying to have.
With respect to transparency, though, shouldn't Kenyans know all the relevant documentation on who this donor is, what are the terms of financing, who's signing on the dotted line? When can we get that information in the public domain?
So by the time the premium financing product is established, my brother, this will be provided. I have said again, this is a complete departure from what has happened in the past. People are not used to knowing things. So we will provide this information. We will have it put out The rates will be clear, who is providing will be clear, and it will be clear for what purpose.
Right. Well, hopefully the disclosure period.
So we are working on it. Allow us also to be transparent and say that this is what we are now finalizing on. And when it is done, we will put it straight on. But I want you to understand the principle.
When will it come to market?
We expect within 1 month to be done. That's our expectation. We are working day and night. But I want you to first understand the principle. Why the premium financing is needed is to equalize any informal person who is not in the cooperatives kind of setting to also not be punished to pay a lot of money which they don't have at once, but to be equalized to the employed people. They contribute, but not monthly, but as their income comes. So you map your income, then you are able to know this is how I will be paying over the year. Because you have it, it's just that it is not, doesn't come, you know, in an extremely predictable manner as it happens. So I just wanted you to get the principle, then you follow us for implementation and hold some of us accountable for it, including the chairman who is in the meeting.
One last question for you. There's a question that's come in here from one of the individuals who's listening to our conversation on WhatsApp, and he's essentially saying, look, the questionnaire that we have to fill in on means testing essentially asks us about assets. Is the assumption here that land, boats, cars, for example, are all productive assets and generate income? Because, you know, as economists, we know that is certainly not the case. You may have a car, it's not necessarily an income-generating asset. Same thing with land, which can be incredibly illiquid and so on and so forth.
Every variable that is put there have been put there after looking at what are the variables that predicts the household incomes based on the 16,000 household data, as I highlighted to you. So if the person asking is an economist, he knows that the key thing is the correlation between the consumption function and the disposable income. So the variables you see there have not just been put there. They have been, we started with more than 1,000 variables. We have gone down looking at what is correlating higher and higher and higher. And when you look at because people have done mean testing in this, and you can compare it with what happened in education. The amount of premium that is coming out is largely a lower bound estimator of the household income for those who have been able to do. And I think we have almost quite a huge number. We have a whole dashboard, again, that is showcasing the mean testing results and how they are coming and the range around which these resources are at. So I want to really also ask.
In the event that someone wants to challenge the premiums that they're being asked to pay as a result of whatever the PMT algorithm.
You challenge. There is a contestation model. There is a contestation model.
Is that in the portal?
Yes, it is. When you finish, if you don't like it, you contest.
And then
when you contest, then you allow for us to use more variables, which we could correct, including direct correction using the community health promoters who you live with.
So those individuals will then come and make an assessment in your house, in your workplace.
Correct.
And so on.
And I want to give you an example of what happened in Kigali. Kigali, when they were doing their own mean testing, they actually went and drew a village on a bed sheet. You draw the village and you write all what you own there. And then they determine the premium based on what you own. Kenya is a more digitized nation. We will not go to write worksheets. We have to train with the variables that we have. We populate the model largely, and we know, underestimates this. But it's a good point to start with, for the sake of fairness and for the sake of charging everybody the same way, regardless of your employment status and where you earn your income.
Right. We've been having this conversation for the better part of an hour, so I want to give both of you an opportunity to make your closing remarks as essentially we come to the tail end of this conversation, because I'm sure we'll get a ton of feedback on the Twitter timeline and, of course, in person in our DMs and email later on. By the end of the year, what are your performance targets? What KPI should we hold you accountable to? Abdi, I'm going to start with you and then Dr. Moy.
Thank you very much. By the end of the year, what you will hold us accountable to is two things mainly. For me, is to operationalize the primary health care that every Kenyan actually has access to primary health care facility to seek services from, and that where they have a choice in terms of public, private mission facilities. That's level 2 and 3. The second thing that you will hold me accountable to is the issue of operationalizing the emergency. The 14-year wait will come to an end, and we will be able to have operationalized that part where every Kenyan who gets emergency services is not asked for a shilling when they are undergoing treatment for that emergency. For me, that's what I'm looking at. But more importantly, we hope to register as many households as possible as well, move away from the current 12 to almost 16 if we intensify our program of registration and make the
16,
60.
16 million households.
Yes.
Okay.
Uh, no, not 16 million households, 16 million adults. The households are 12 million generally. So for me, I'm looking at 16 million adults from the current 12 million, 12.8 million adults that we have, and hopefully map out all the dependents between now and then, because that is one area that we need also to make it robust. The other thing is, by the time we are the end of December, you will be able to have the social health insurance, the social health authority app, where you will be able to update your profile. You will be able to access and see your patient records, and you will see which hospital you attended. If and you have not attended, you will be able to raise a dispute and say, I have not attended this. So you will see all the claims that you have been, that hospitals have claimed on your behalf. And if you have any issue with them, you will be able to say, I have a problem with this. And that app, for now, it's the web portal, but it will be a mobile app that you can easily download from the Play stores that we have. The other thing is to help our cooperatives and enter into agreements, mainly the SACCOs and the informal cooperatives that we have, to prepay for their members and make it easy, and allow them to contribute on behalf of their members. Finally, to maintain the transparency and keep everything as openly as possible, including even the contracting of providers, which is done digitally, online, with minimal human interferences, and make it as short as 30 days, because those are things that we have already predetermined and agreed on, and that's what the act, and that tells you the people who've designed the laws have thought through in addressing the issues. Finally, my appeal is to all Kenyans that paying out of pocket is not possible. Even for the rich, it's very difficult. Health is generally expensive. The second thing is no one knows or can plan for when to fall sick. So I would urge that instead of paying healthcare out of pocket, and instead of waiting when they fall sick, it's good practice that we adapt prepayment, even for our relatives who might not be aware, and educate them that it's better when we contribute all of us into one basket then we can be able to have better output. And more importantly, to continue sensitizing Kenyans to understand what are their inputs and where do they need to input. For even benefits and tariffs, Kenyans have been given the opportunity to petition the committee that has been established, which is not at SHA, but at the university, to participate in shaping what diseases we need to prioritize and what are the tariffs that we need to increase or reduce, and how do we cover more people going forward. Thank you very much
As
for this
one
opportunity.
one last one last
Yes,
question for you,
yes.
Abdi, with respect to transparency, because NHIF
Yes.
by law was also required to provide audited reports every year. And I believe that's the exact same thing with SHA. NHIF, of course, didn't comply with those requirements in the law. And as part of efforts to essentially bridge that trust deficit, it's a massive one. We've discussed it over and over this hour. Can you commit to us that SHA will be providing regular updates, if not every year, every half year, on the financial status of the enterprise?
Yes, I commit to that as long as I'm the chair.
All right, Dr. Mwai, your closing remarks, and then we'll wrap up the space.
Thank you very much, Lama, one, for having us. I want to remind people that when President Kibaki in 2003 or there announced free primary education, there was no plan, there was no system, there were no teachers, there were no classes, but the government was able to reorganize itself to provide education to its people. The health, we didn't. We went through a legislation that ideally did not bear fruits. We got another chance within the past government to do pilot. We piloted in some few facility counties, and that didn't work. But all these have developed evidence that is important to shape our discussions going into the future. And contrary to other reforms that have happened in this country within this government, one of the reforms that have followed to the letter, the recommendations that have come from experts, is this health reform. Within the trust deficit that we talked about and the many promises that may seem like they have not been met, I want the people of Kenya to know that the changes that have happened within this reform for health is actually a culmination of years of experience from from National Hospital Insurance Fund, which changed to National Health Insurance Fund, which is changing to Social Health Insurance Fund. So it is not that NHIF has been static, it has been growing. And this is, I would call the social insurance 3.0, because we started from NHIF, which was National Hospital Insurance Fund. They changed it and added some benefits to become the Social Health Insurance Fund. And now we are getting to the universality of the people with the Social Health Insurance Fund. So that is it. And it's a eroded, better NHIF, which promises that better things can be done in a better manner. I also want to highlight that there is a report that was written very well in 2019, Lama, and it would be good for this report to be shared, more so for Kenyans who can be able to read, to look at the challenges that were identified by the panel of experts and the recommendation therein that were done. And then triangulate that with the act and the regulations. And if there is one problem that has not been addressed in that document that is critical, please come back to us for a discussion, because we have tried over the time, we have gone through various stakeholder engagement to actually solve each of those problems, to make sure that we are not guessing when we implement this health agenda as it is. Trust is earned, and we know that there is a huge trust deficit, but we hope that the Kenyans will also give a chance to first look at what are the changes that have been made to make sure that all Kenyans, regardless of their income levels, age, as well as diseases that they face, they will not be incur catastrophic spending and impoverishment. I also want to assure the middle class who have been contributing premiums for their families who are not well off, that when the government takes into consideration the premiums of the indigents and the elderly, it is only expected that the middle class will just pay for the contribution of themselves only. And therefore, the problem we have been having of the middle class having to contribute to support the household strains for health then will have been reduced or eliminated. And this will become easier in terms of increasing disposable income in the hands of those who have been paying for private insurances, but they also pay for the social insurance for their people. But also when they get sick, because some of the majority of those diseases that were causing catastrophic spending were not actually covered, then they had to also go and contribute in halal base for health. So that's the kind of thing that we will. And when you look at the aggregate impact, it's far less even than the marginal increase in 2.75 that the middle class and higher level, not even middle class, higher level are actually incurring. Lastly is that we hope that the healthcare sector will come together and rally itself towards change that is happening to make sure that we have a stronger healthcare system where we all discuss providing solutions and not only problems without having to agree on the optimal pathway of solving them. That means that we are open. We should receive suggestions. We should also accept that the social health insurance principle is a solidarity principle, that 95% of the people in the globe or in a population do not require expensive healthcare covers or care, but 5% require extremely huge cost of care. And therefore, when we all come together, we contribute based on our ability to pay, we can be able to shield the 5% when they require extremely high cost of treatment, as you have seen. So thank you very much. And I hope this is not the first time and the last time. Let's keep the discussion ranging. Let's have the problems. Let's, bring them out. We will not promise that challenges will not be there. We'll promise that we'll work as much as we can together to solve the problems as they come.
All right.
Thank you.
Well, we've heard from our two speakers today, Dr. Moy and, of course, Dr. Abdi Mohammed, the chair of the Social Health Authority. And, of course, Dr. Moy is the presidential health advisor on policy matters in this respect. I'm sure that one of the things that is right at the top of the list, based on the feedback that we're seeing, at least on the timeline at the moment, would be to say, well, I really don't have trust in the Kenyan state at the moment. Therefore, I would like to opt out. We'll see how this plays out over the next few years. Gentlemen, thank you very much for your time this evening. And of course, to you, our audience, it's going to be a public holiday here in Kenya tomorrow. But for those of you who are not enjoying a public holiday, we don't take your time for granted. Thank you very much for taking time here. Please keep sending your feedback to the Mwango Capital account. We'll certainly look at it and hopefully build on that to essentially figure out what issues need to be addressed in future and how best those can be dealt with.